Dr. Huang's biography. I've got it. Thank you, Annie.
We are live.
Good evening, everyone. Welcome to iFocus Online Lecture 141 and Glaucoma Session 45. And this is a sequence of international masterclasses. And today we have with us Professor David Wang, and he will be talking on OCT in glaucoma, the current status and future prospects. And I request Vanita ma'am to please introduce her.
Yes, thank you very much, Rolika. And, it's a very special day. Our team, Center for Sight, brings yet another ophthalmologist who needs no introduction to any audience worldwide. But of course, it gives me great pleasure to introduce him to our budding ophthalmologist. Professor David Wang is associated with the Oregon Health and Science University. He is the professor of ophthalmology at the School of Medicine. He's also the professor of biomedical engineering. He's the associate director as well as the director of research at the Casey Eye Institute School of Medicine, and holds Martha and Eddie Peterson Professor of Ophthalmology chair. His education, just as his work, is absolutely illustrious. He did his bachelor's and master's in electrical engineering at the Massachusetts Institute of Technology, followed by his MD and PhD at the Harvard Medical School and associated with Massachusetts Institute of Technology. He did his fellowship at the Emory University in 1997-98 in cornea, external diseases, and refractive surgery, and he received his board certification in 1999. He is, of course, known for his innovations in applying laser and optical technology to eye diseases. He is the co-inventor of optical coherence tomography, working with his mentor, James Fujimoto, and 3 others in the lab together. As we're all aware, possibly more than 30 million procedures of OCT are done worldwide in different specialties in ophthalmology, and his seminal article on optical coherence tomography, which was published in the journal Science in 1991, has more than 14,000 citations. He has issued, he has to his name 33 patents in the area of OCT and geography, etc. And since the invention of OCT, in the 1990s and its commercialization in the 200s, post-millennium, Dr. Huang has further contributed to the development of swept source OCT, anterior segment OCT, Doppler OCT, as well as OCT and geography techniques. Therefore, his areas of interest are OCT and geography, biomedical optics, biophotonics, imaging, glaucoma, and keratoconus. He has been the principal investigator of 5 National Institutes of Health research grants in the past 2 decades and has over 300 peer-reviewed articles with a whopping 40,000 citations. He's also edited 11 books. He has received several honors and awards, the most eponymous of which would be, several really. Antonio Champalimaud Vision Award, the largest prize given for ophthalmic research, then the Jonas Friedenwald Award, one of the highest awards given out by the Association for Research in Vision and Ophthalmology, or ARVO, better known. Fritz J. and Dolores H. Russ Prize, given by the National Academy of Engineering for outstanding bioengineering achievement that improves human condition, and of course, Senior Achievement Award from the American Academy of Ophthalmology, amongst several others. So Team Center for Sight extend a very warm welcome to this master innovator delivering a masterclass on OCT in glaucoma, current status and future prospects. Stage is all yours, Professor Wang.
Well, thank you, Dr. Pathak Ray, for that very kind introduction, and I thank you all for the honor of presenting really just halfway across the globe. It's really amazing that we can do this remotely. And
possibly one of the silver linings in the cloud called the pandemic that you can connect. But we are honored for, it's way early in the morning for you, and we are very grateful that you could join us today live.
Thank you. And I'm going to talk about glaucoma. As you know, I'm a cornea specialist, but most of my time is spent doing research, and my biggest research projects are actually in glaucoma. And I have done OCT imaging research in glaucoma for about 2 decades now. And I'm going to talk about the current status and future prospects. I do have financial interest in OCT and geography technologies with regard to OptiView company that commercializes this type of technology. So one obvious application of OCT in glaucoma is early diagnosis, which is important because this is an insidious disease that causes irreversible damage. So we want to catch it early and treat it when the treatments are most effective in the early stages. And I want to start with a concept of the tipping point, which is introduced by Dr. George Schumann and his colleagues. And the idea is that in the early stages of glaucoma, which is the kind of on the right side of this the tipping point, there is a lot of reduction of nerve fiber layers, but very little change in the visual field. So in this early stages, diagnosis is best done with structural measurement by OCT, such as the overall average nerve fiber layer thickness or other structural measures. While in the later stages, after you've lost about 40% of the nerve fiber layer, and that the tipping point is about 70 to 80 microns in terms of the average nerve fiber thickness. So beyond that, the progression of visual field start and become steeper. And in the severe stages of glaucoma, actually nerve fiber layer reaches a floor, and it's better to use visual field to monitor the progression. So that's the tipping point concept that point out the utility of OCT in the early stages for diagnosis and also monitoring. So often we perform studies of diagnostic accuracy using visual field as the gold standard. But if you do that, then you cannot really compare new modalities such as OCT with visual field in terms of their relative value in diagnosis. So we performed an analysis where we put OCT, visual field, and disc examination all on an equal footing in comparing their diagnostic value. So to do this, we use progression over time as the defining characteristic of primary open-angle glaucoma, because we know glaucoma is a chronic progressive disease. And then we compare the sensitivity of OCT, visual field, and disc examination for diagnosing progressive glaucoma. And this is this analysis is performed using the data set collected in the advanced imaging for glaucoma study that was conducted between 2003 and 2013. I was a principal investigator of this multi-center study that involved 3 clinical centers, 643 patients, and 145 normal control subjects. In this project, the AIG consortium, we developed macular ganglion cell analysis, and that's one of the biggest achievements of this project. And the metric we used was the ganglion cell complex, or GCC, that is the combined thickness of the nerve fiber layer, ganglion cell layer, and inner plexiform layer, the axon cell body, and the dendrites of the ganglion cells. And this turned out to be a very useful diagnostic and monitoring metric, as I will talk about later. And it's a longitudinal study where we could use the data to look at the visual field conversion and glaucoma progression over time. And these are some of the key study publications listed down here. So from the AIG data set, this analysis selected participants with at least 7 complete visits. And these visits were done at 6-month intervals for the glaucoma patients. So we had 326 eyes that met this criteria, and they were as early as glaucoma suspects, which means they only had suspicious disc, but no visual field defects, actually no, they had elevated intraocular pressure, or are the fellow eyes of glaucoma, and pre-parametric glaucoma, where they only had optic disc defects, but no visual field damage that were detectable yet, and then parametric glaucoma, where they did have definite visual field defects. So together we had 326 eyes, and they were monitored for more than 3 years. And out of these, 60 eyes had progressive glaucoma, and this is the endpoint that we try to predict using baseline data. And the methods of diagnosing glaucoma at baseline that were used include disc abnormality evaluated by either photography or clinical examination by the enrolling doctor, and OCT by evaluating either the nerve fiber layer, GCC, or ganglion cell complex, and the optic nerve head at the 1 percentile cutoff points. And then visual field using pattern standard deviation, glaucoma hemifield analysis, and also by the doctor looking at the damage pattern to make sure they're compatible with glaucoma. And we found that actually most of the abnormalities were detected by disc examination, followed by OCT and visual field in this cohort. Among the OCT criteria, we found that the optic nerve head analysis actually was the most sensitive, followed by nerve fiber layer and ganglion cell complex. And the combined specificity was a little bit better than 95%. Among the disc examinations, the photographic grading at the Bascom-Palmer Reading Center, led by Dr. Rich Parrish, was actually far more sensitive in picking up glaucoma than the clinical examination. So if you have Dr. Parrish's expertise and time to really carefully examine photograph, it is a very sensitive method of detecting glaucoma, but of course, that is not always available in clinic. And the agreement was only fair, which is typical for a subjective interpretation by physicians, by humans. We used 3 different methods to detect progression. And as before, we apply OR logic. If any of these criteria were met, then we diagnose the eye as having progression. And these criteria include OCT criteria, where we use linear regression to look at the trend of change in nerve fiber layer or ganglion cell complex, apply the P less than 0.05 criteria for a statistically significant progression. Visual field trend analysis using visual field index and mean deviation, and serial photographic grading, again at the Bascom-Palmer Optic Disc Reading Center. And we found that OCT was by far the most sensitive in picking up significant progression, followed by visual field, and serial disc photograph progression, even by experts at Bascom-Palmer, was not very sensitive in picking up progression. Among the 2 OCT parameters that we use to detect progression trend, GCC was significantly more sensitive than nerve fiber layer. So this is actually fairly significant result, because most people are more familiar with using nerve fiber layer to monitor progression. But actually, this result indicate that you should be using ganglion cell complex based on the macular scan as well, because this is even more sensitive. And in terms of the sensitivity of detecting progressive glaucoma, comparing the 4 different methods, disc photography was the most sensitive. Again, this is read at the Bascom-Palmer Reading Center, so this is not really available for everyday clinical use. Among the 3 methods that you can use clinically, OCT was actually the most sensitive, followed by clinical disc examination and visual field analysis. And so the conventional methods of picking out glaucoma is based on visual field and clinical disc examination. And these has a combined sensitivity of 0.45. And if you add OCT, it does significantly enhance it. If you look at single diagnostic parameters and evaluate their diagnostic accuracy by the area under the receiver operating curve, among the OCT methods and overall, actually the disc rim area was the most accurate. And this is measured on the OCT scan of the optic nerve head on the OptiView Avanti RT view, which is relatively simple. So I think more advanced optic nerve head or optic disc analysis with the newer OCT system that have can scan in more detail volumetrically really has potential for further improving diagnostic accuracy. And this is followed by nerve fiber layer and ganglion cell complex. Visual field is performed relatively poorly, and this photography, vertical cup to disc ratio, actually also performed quite well. So overall, I conclude that for early diagnosis, OCT disc parameters actually perform the best for the clinically available methods. So that is a parameter that we should pay attention to. Again, this is a little bit surprising because most people primarily use nerve fiber layer thickness on OCT to pick up glaucoma. And the macular scan is important because the ganglion cell complex, or GCC, is very good at monitoring progression. And OCT is synergistic with the disc exam and visual field in detecting early disease. How about monitoring progression? Glaucoma specialists spend most of their time not trying to screen for glaucoma, but really monitoring their patient over many years to assess their rate of progression and see if they need more intense intervention or not. So it's a monitoring game most of the time, and so this is a very important part of glaucoma management. So in the AIG study, we have a lot of data over years to monitor progression using either visual field parameters such as the VFI or mean deviation, also discrete event by the glaucoma progression analysis program on the Humphrey field analyzer. From the OCT, you can monitor the trend of change in GCC and NFL, and monitor progression in terms of microns per year loss of tissue. And in the AIG study, we found that using OCT and progression being defined with OCT as a significant trend in either GCC or NFL loss, you can pick up progression with more sensitivity or earlier than monitoring visual field trends. In general, about 2 years earlier on the Kaplan-Meier plot. And if you compare the 5-year performance, OCT picked up a significant progression trend more than twice as frequently as visual field. So the AIG study primarily comprised of early glaucoma patients, either pre-parametric or early parametric glaucoma. So I think that explains why there is such a big advantage for OCT. If we break it into stages, we find that OCT is much better in detecting progression, but in moderate to late parametric glaucoma, visual field is slightly better than OCT. So in terms of the longitudinal progression data, we found that OCT is most useful in monitoring progression in early glaucoma, whereas visual field is more useful in moderate to late stages. So in summary, from the AIG study, we found that OCT had the best sensitivity for detecting progression, and it's important to monitor the macular GCC because that's more sensitive than the peripapillary nerve fiber layer thickness. fundus photography grading by the Bascom Palmer Reading Center had the highest sensitivity in detecting progressive glaucoma. But of course, the reading center is not available for general clinical use. OCT is more sensitive than visual field and clinical disc examination at picking up progressive glaucoma. And special attention should be paid to the disc rim area, which actually have good performance in early diagnosis. And on the OptiView, RTView, there's this parameter called global loss volume, and that actually worked best for nerve fiber layer and ganglion cell complex. And for this analysis, the OCT specificity was 95.5%, whereas the specificity for the disc reading and visual field were not directly assessed in the AIG study, but based on the visual field parameters, definition should be similar, and for disc analysis, the specificity was probably lower. And clinical disc examination was actually good at predicting the speed of visual field progression. So all three modalities, OCT, visual field, and disc examination, are all able to predict progressive glaucomatous optic neuropathy. But visual field is the least sensitive and should be supplemented by a structural evaluation, either disc examination or OCT. And when using OCT, don't just look at the nerve fiber layer, but also look at the disc rim for early diagnosis, and look at the macular ganglion cell complex thickness when you're monitoring progression. Dr. O10 in our research group has recently looked at nerve fiber layer reflectance analysis and found that it can enhance diagnostic sensitivity. And I'll go over this data briefly. So it's been known for a long time that nerve fiber layer reflectance is reduced by glaucoma because of loss of axonal content. But it's difficult to use this clinically because the signal strength of OCT varies a lot between scans and between individuals because of things like cataract or dry eye or focusing problems like astigmatism that can all affect the apparent nerve fiber layer reflectance. So what is needed is algorithms that filter out these extraneous noise and measure the intrinsic nerve fiber layer reflectivity. So for this analysis, Professor Tan took the nerve fiber layer and measured the OCT signal in the nerve fiber layer along with a reference layer, and he used the PPEC or photoreceptor pigment epithelium complex, basically an outer retinal band, and also measure the reflectance or OCT signal. And then when you take the ratio, you kind of normalize the measurement so that you reduce the effect of cataract or astigmatism factors that would reduce the reflectance in both of these bands. So this ratio map highlighted, for example, in the inferior temporal area, a defect in the nerve fiber layer quite clearly already. In addition, he applied a azimuthal directional filter to reduce the variability in measuring reflectance associated with different incidence angles. Because when you take OCT images, the operator in these earlier instruments definitely don't really have good control of where the beam enters a pupil. So the incidence angle on the retina can affect the reflectance. So he did filtering to reduce that. And this even further enhanced the visualization of this nerve fiber defect. And then we did analysis by superpixels that follows the nerve fiber track. And this helped us recognize patterns of these defects. And so he was able to find in glaucoma these wedge-like defects that are characteristic of glaucoma. And these patterns are consistent with the associated visual field defects. So this focal loss analysis has very high diagnostic accuracy and 99% specificity. We found that if in parametric glaucoma, we can have this focal reflectance loss analysis can have 97% sensitivity, which is very high, higher than average nerve fiber layer thickness, which picked up 71%. And in terms of pre-parametric glaucoma or very early glaucoma, this reflectance analysis more than double the diagnostic sensitivity. So I think this is a very promising direction for the future. I don't think reflectance analysis are really available on commercial machines yet, but this research indicate that they should be for early diagnosis. So the conclusion of this, the paper that we published this year in Translational Vision Science Technology is that nerve fiber layer reflectance analysis can greatly enhance glaucoma diagnostic accuracy. And there are a few methodologic improvement that made this possible. One is using focal loss analysis that follows the track of the nerve fibers. Another is this azimuthal filtering that reduces the noise due to incidence angle variability. And next, I want to talk about a relatively new technology called OCT and geography and the role that can play in glaucoma diagnosis. So OCT and geography is made possible by high-speed OCT, and the speed of OCT has been improving since our original invention, where the first prototype that's used in clinic only operated at 40 hertz or 40 axial scans per second. And now you can have commercial system that run at 200 kilohertz or 200,000 axial scans per second. If you plot this over time and did this logarithmic regression fitting, you find that the speed doubles every 2.4 years. So this is the Moore's law of commercial OCT speed that made OCT and geography possible. So this high speed using Fourier domain OCT make fully sample volumetric imaging a reality today. And this also enabled us to incorporate a fourth dimension of time by comparing between repeated B scans to detect changes in the OCT signal that indicate motion and flow. So the principle of OCT and geography can be made clear by analogy to serial video frames. In this case of tennis balls flying through the air, you can think of these as blood cells. And when you subtract the two frames, you remove the static structures, and that enhances the moving structures, such as the blood cells. And the flow signal can be seen here, the flying tennis balls. The shadows on the wall, though, is also moving and also highlighted by this simple detection scheme. And this is the shadow graphic flow projection artifact, which I'll also discuss later. So in OCT and geography, you take a series of OCT scans and you compare the signal at each location. If you're in a vascular voxel, you find that the signal fluctuates due to flow motion. Whereas in static tissue, the reflectance signal should be fairly steady. So this motion provides contract, so you don't need dye injection. And the change in OCT signal can be detected by looking at either the amplitude or phase, and can be calculated by decorrelation, variance, or ratios. And in general, you need high-speed OCT and an efficient algorithm to make this OCT and geography feasible. A very efficient algorithm is called split spectrum amplitude decorrelation and geography that was developed in our laboratory. And in this algorithm, you take each OCT B frame and decompose it into its spectral components. And so you split the spectrum to obtain multiple lower resolution OCT frames. And these frames have independent speckle patterns because they're in different spectral bands. So you compute the decorrelation in these lower resolution frames and then recombine it to obtain a decorrelation signal that is more sensitive to flow. And this is really equivalent to increasing the number of image frames without additional scan time. And we demonstrated that this improves the signal to noise ratio of flow detection by a factor of 4 and allows one to obtain high quality angiograms like the one on the right with only taking 2 B scans at each position. So it doesn't take much more time than a purely structural OCT frame. So I want to explain what the projection artifact is in OCT and geography. So on the left, you see this cross-sectional OCT and geography image, and you find that these retinal vessels, shown in purple here, streaks down because of projection artifact. And in the outer retina, the photoreceptor and RPE layers, these tails reappear, and these must be artifacts because these layers are in a normal retina avascular. And if you segment the different retinal layers and do en face projection, you see that you see the superficial retinal vessels very nicely, but it's duplicated in the deeper layers. And this is what the projection artifact look like in deeper slabs. So this really makes it impossible to cleanly visualize the deeper plexuses, such as the intermediate and deep plexus. In the outer retina, which should contain no blood vessel, you see a very dense projection artifact, and that really needs to be removed. And fortunately, we have developed effective algorithms that can use a computer to remove these artifacts automatically. And these are two of the key publications that describe this algorithm. And you can see that it effectively removed the artifact, because now on the cross section, you can see the blood vessels as discrete round structures without their long tails. And in the unfast projections, you see the pure capillary pattern of the intermediate and deep plexus clearly. And in the outer retina, most of the projection has been removed. And now we apply this new technology to glaucoma. And I want to thank my colleagues at KC Eye Institute for their help in this research to investigate OCT angiography in glaucoma. So with projection resolved OCT angiography, we can actually detect 4 plexuses in the retina. The nerve fiber layer plexus and the ganglion cell layer plexus together comprise the superficial vascular complex. And this is what glaucoma primarily affect. There's also a deep vascular complex that is made up almost purely of capillaries. And they are the intermediate and deep capillary plexuses deeper down in mid-retina. So in glaucoma, if you take macular OCT angiography scan, looking at this lower left image, you see an area of reduced capillary density that form an arcuate pattern of damage that's characteristic of glaucoma, and that's seen in the superficial vascular complex, or SVC. If you look at the deeper plexuses, ICP and DCP, they are no different from normal. The glaucoma don't really affect them very much. In the lower right, you can see that GCC shows this defect very clearly. And in the peripapillary retina, the glaucomatous defect is most clearly seen in the nerve fiber layer plexus. And in this area, this plexus is also called the radial peripapillary capillaries. And if you focus just on this plexus, you can detect glaucoma with high diagnostic accuracy. In this paper, where we described this new metric for detecting glaucoma, we were able to achieve a AROC of 0.985 in a group of mostly early glaucoma. So since we already have OCT, why do we need OCT angiography? Well, I think the main reason is that there is less of a floor effect. So on the left, you see that if you plot the nerve fiber layer thickness on the vertical axis against visual field mean deviation, you'll find that there is rapid reduction in nerve fiber layer thickness in early glaucoma. But in severe glaucoma, the nerve fiber layer thickness stops changing. And that's the floor effect. So you cannot really use OCT to monitor glaucoma in the later stages. Whereas in OCT angiography, if you look at this plot on the right, that plots the nerve fiber layer vessel density around the disc, you find that it's more linear with the visual field mean deviation, so that there's less of a floor effect, and you can see changes in the vessel density even in severe glaucoma. Of course, in the extremely severe stages, you still have a floor, but that will be seen in only the extremely severe stages. There's also evidence that OCT and geography can help early diagnosis in 2 papers that found in the pre-parametric glaucoma stage. You more often find reduction in vessel density rather than nerve fiber layer thickness. And I interpret that as OCT and geography being able to detect the reduced metabolism of sick ganglion cells, which cause the blood flow to be reduced. And this can occur before ganglion cell apoptosis and the thinning of GCC and NFL. So I think OCT and geography's main application will be monitoring glaucoma progression. And I think a tool for doing that is to use the vessel density or capillary density measurements to simulate visual field, to bring it into a scale that's more familiar to the clinicians and conforms better to the way glaucoma progress, which is logarithmically. So why do we need to replace visual field with a simulation? Well, the main reason is that visual fields are poorly reproducible, so that it actually takes 3 visual fields in series to really diagnose glaucoma with confidence. And that result was from the ocular hypertension study. And Medeiros et al. Has done statistical analysis to find that to detect a trend of progression, you need many visual fields to have sufficient confidence. So even someone with rapid progression at 1 decibel per year, to detect significant progression with 2 tests per year, you need 4 years, by which time there will be a 62% loss by retinal sensitivity already. So visual field on an individual basis is not really sensitive to detecting progression. We need something more precise, less noisy. You can use structural OCT, but as I demonstrated earlier, it doesn't work that well in the later stages. So we also have done work to convert the nerve fiber layer thickness to a logarithmic scale, and that does extend its dynamic range in tracking glaucoma, but only a little bit. So this was published in 2019. But with OCT angiography based nerve fiber layer plexus mean deviation, we can really track glaucoma down to a fairly severe stage. And we want to convert this to a logarithmic decibel scale so that the rate of progression can be compared fairly between different stages of glaucoma. So the way we simulated visual field was by sector, and these sectors were originally developed by Dr. Ted Garway-Heath to look at the disc, and Dr. Oct has extended this sector system along the trajectory of nerve fibers, and we defined 8 different sectors. And within each sector, we can measure the nerve fiber layer plexus capillary density. and then convert that to visual field equivalent decibel scale by nonlinear regression against actual visual field. And this was published in the American Journal of Ophthalmology in 2020. And we look at a study group comprised of various severities of glaucoma as well as normal controls. Here are some examples. So in the normals, the simulated visual field would be all green or all normal, agreeing with the actual visual field. In early parametric glaucoma, you see that in this example, the location of the visual field defect agree well between simulation and actual visual field. Although the OCT and geography-based simulation, the nerve fiber layer plexus mean deviation showed more severe disease than the actual visual field. In this moderate example, the simulation and actual visual field agreed almost perfectly. In this advanced glaucoma example, the pattern matched well, but the simulation show less severe disease. So the simulated mean deviation was more reproducible than the actual visual field mean deviation, and this difference was significant. And this lower variability, 0.63 dB compared to 1 dB, is really what we're looking for, because this shows that it has potential for more precisely monitoring progression with less noise. The nerve fiber layer plexus mean deviation also has very high diagnostic accuracy, 97% and 99% specificity in this group of glaucoma patients. And that's actually better than raw nerve fiber layer plexus capillary density or nerve fiber layer thickness. So just by converting things to a decibel scale, you also improve diagnostic sensitivity. This is a Bland-Ullman plot to assess agreement, and the simulation and actual visual field agree well, except in the advanced stages where the simulation tend to underestimate the severity. We have followed a small group of patients with simulated versus actual visual field, and we found that in the pre-parametric stage, the nerve fiber layer based mean deviation was most sensitive in picking up progression, while in the parametric glaucoma stage, the OCT and geography based simulation was better. Actual visual field actually was not able to pick up progression in such a small group in such a short time, over 3 years. And this is one example where you see steady progression on OCT and geography with reduced capillary density and worsening simulated visual field, but the actual visual field fluctuate too much to really pick up the progression. And there was also a slight structural thinning in this example. I will also want to talk about focal analysis to detect locational damage. So these are the raw OCT on fast display of the superficial vascular complex. And you can see areas of glaucoma damage clearly in some areas, but other areas are kind of, you see relative reduction. It's not clear if that's significant or not. A computer algorithm can determine significance better. So, and this analysis is called the Low Perfusion Map. So it's the red and green map that shows the area of damage very clearly, and it matches the visual field very well. And these are some typical patterns we see. And the arcuate and biarcuate, of course, makes a lot of sense in terms of the nerve fiber bundle trajectory. And in early disease, you have scatter loss, and late disease or diffuse loss. So it all makes sense. It's a good way to localize the location of damage. So I'd like to thank the support of National Eye Institute, Research to Prevent Blindness Foundation, and OptoView for our research. And our research group is called the Center for Ophthalmic Optics and Lasers, or COOLAB. And please visit our website, coolab.net, for more information on our research. So I'll stop there. Thank you for your attention.
Thank you very much, Professor Wang. That was so fascinating, especially the OCT and geography, of which at the moment, at least here, we have limited application. So we really learned a lot. I'd request Dr. Pradeep to give us his impressions, and then we'll take a few questions if you don't mind, if it's not too late for you.
No, of course, I have time.
Thank you so much. Very kind.
Thank you, Professor David. Just amazing, excellent, superb, and wow, it was a beautiful learning. Every single word had a meaning. Every single slide had a meaning, and we learned a lot. So you taught us, when the OCT came, we started looking at the RNFL, and that was the diagnostic for us, that yes, there is a RNFL thinning, and the patient has a glaucoma. We used to monitor with the RNFL thinning. Then we moved to the GCC, and now today you taught us that you should look at the disc rim area. The disc rim area is the most critical. That is what you taught us today, and it was beautiful. The only thing which I have in my mind, that is it really that the machine checked the disc rim area with the perfection, or is there any fallacies because of probably the anterior insertion of the RPE or the Brooks membrane over the disc? So probably erroneously, it may not calculate appropriately. But yes, the monitoring might be very precise. That much I can tell you. So then you took us to the reflectance, and that was amazing. And the images you showed was beautiful, lovely. And still, is it the sign of the revival for again the polarimetry technology? And then you move to the OCT NGO, and the OCT NGO was also, again, you showed the duplication of the vessel is the most important aspect, where we get confused, and the registration also is poor, and so that the serial analysis becomes little difficult. So how to overcome it, and probably what I understood, if it is correctly, then the NGO view has a capability of overcoming that thing. Is that right? So there are so many other questions as well. But in a nutshell, I would say that that was an excellent lecture, excellent talk. That was a deep learning, and probably we have to see your lecture time and again to learn too many things. Thank you very much, Professor David.
Well, I think that out of all the diagnostic parameters I talked about, the macular GCC is probably the easiest to use, because generally the registration is excellent, and the magnification variation in myopes is relatively a small effect. So there are not many artifacts, so it's easy to use. There are very few pitfalls. So I highly recommend that. The nerve fiber layer, of course, is the most familiar to us because it's been studied for glaucoma since the the mid 90s. So we had 20 years experience using it. I think the main pitfall for the nerve fiber layer is that the magnification effect is relatively large. So often in high myopes, it appears thinner just because the scan is scanning a bigger circle around the disc where it's normally thinner. So you have to watch out for the artifact, but other than that, it's also fairly reliable. The rim area that I talked about was measured with the RT view, which simply uses a horizontal section at a fixed distance above the RPE. So it's relatively primitive, and I was surprised how well it performed, but it performed very well. It's hard to use because there was no normative classification. It's not marked in red or yellow or green on the machine itself. So you have to have your own diagnostic criteria. So that is the pitfall. That make it really rarely used because clinicians doesn't know how to really interpret it. And I think later improvements such as the Brooks membrane opening minimal rim width that was introduced by Claude Burgoyne, Bauer-Schoen, and others was a significant improvement. I think it's more reliable. And if you have that, I think you should use that. But even there, I think it's harder to use because these parameters are affected by the disc size and also magnification effects. So both variations in the disc diameter and variations in myopia really would affect the diagnostic cutoff, and those are not provided on the machine. So it's really difficult to use. And I think a lot of work needs to be done by the commercial companies to make those parameters control for disc size and for the degree of myopia to make them really useful. But I think if they do that, it would be a really sensitive way of detecting early glaucoma. I think the nerve fibular reflectance is even more sensitive, but it's not really implemented on commercial machines yet. So it's really hard for clinicians to use it. As you see, we had to do a lot of analysis, like taking ratios of reflectance, filtering out angular variations, doing focal analysis. So it's not that simple to filter out the noise. And so you need special algorithms to really use it. But when you see on fuzzy image though, a human can often detect these loss over an arcuate bundle shape. And I think so qualitatively, you can already use that by your human image processing, by looking at the unfuzzy images. And the OCT and geography, as you mentioned, require accurate registration. And I think on the new OptiView system, the Solix, there's actually pretty good positioning around the disc and tracking of the capillary density. So it's a relatively new device and algorithm to monitor that over time. But I think from the small amount of data we have, it appears to work well. And I don't think it's any better than monitoring GCC or nerve fiber layer in early stages, but for moderate to late stages of glaucoma, I think the capillary density will detect glaucoma progression better than structural measures, because those structural measures would have hit a floor effect. And no commercial machine have our visual field simulation yet, but I think that's a very useful approach, and I hope the commercial companies will adopt that idea. Because glaucoma really progresses in a logarithmic fashion. You don't lose 2 microns of nerve fiber layer a year over the entire disease course, but you might lose 2% of your nerve fiber layers over the disease course if you have the typical course of glaucoma. It's kind of proportional to the amount of tissue you still have left, or amount of perfusion you still have left. So it's better to convert things to a decibel scale. And I hope to convince more people that that's the unit that we should adopt.
Right. Well, thank you for that. I just wondered, the OptoView has the ganglion cell complex, obviously, but if there are people who are using other machines that are commercially available, can that be seen as equivalence, where the other measurement modalities are being used, or they cannot be used interchangeably? Because
I think for practical purposes, they're very close. There is subtle differences. If you look at the ganglion cell layer, or the ganglion cell layer combined with the inner plexiform layer, GCIPL, you are better able to localize the disease.
Right.
So for example, if you want to distinguish bitemporal hemianopia versus ocular defects in glaucoma, or altitudinal defects, by looking at GCIPL, you would have a more precise pattern and be able to distinguish between them better. But GCC, though, is measured more precisely because the boundaries are so sharp.
Right.
So the repeatability and reproducibility is better. So for monitoring glaucoma, I think GCC is more sensitive for detecting small changes. And there's actually a paper that demonstrates that GCC has that advantage over GCIPL. So they have, I think for monitoring disease, GCC is better. For localizing disease, GCL or GCIPL is better. But the differences are small, and I think you should use whatever you have.
Okay. There are several questions. I think all of them actually boil down to just one point, is that what do you think are the limitations of the OCT technology? And I think, to clear the cobwebs, especially in the minds of these budding ophthalmologists, I think that is best addressed by yourself.
The limitations of OCT, I think the current OCT machines with the high speed and tracking and volumetric scanning really has a potential for very high performance in glaucoma evaluation. But it's an area that requires really a lot of algorithmic improvements. You need reference populations, controlling for variables, structural variations, and refractive error cause variations. to make the diagnosis much more dependable and robust. That's probably the main limitation. With even higher resolution systems, you can see really fine anatomic changes, loss of very small bundles, or even see laminations within the inner plexular layer. And you can control for the incidence angle better, which would improve the visualization of the reflectance. So those are technical hardware improvement that could also improve the performance.
So really what you're saying for the, increase, get more normative data into the machines for small discs, maybe large discs, maybe myopes, and so on and so forth.
That's right. Yeah. For accurate diagnosis, you need to control for those common variations.
And what about the pediatric population? Obviously.
Controlling for age in that range. Yeah, that would be really useful.
Because there's none of the machines, as far as I'm aware, have any normative database in the
It's a difficult problem because each machine have a 10-year lifespan, and every time you have a new machine, you have to establish new database, and that gets to be very expensive, even for these moderately sized companies.
Because what I feel is that in children, of course, doing visual fields is well nigh impossible. So possibly this objective measurement would be way more useful in the pediatric population. I mean, obviously after a certain age, not in the very young, and therefore, I strongly feel about the lack of the pediatric database. And I have one last question here: is how would you define rapid progressors? Is it loss of one mean deviation or two? Is there a figure? Is there a definable figure for rapid progressors?
I'm not sure there's a consensus, and if you look at microns, the definition is different.
Right.
1 micron per year is slow in the beginning of the disease, but 1 micron per year of nerve fiber layer or GCC loss would be fast for late diseases. So I think you really need to convert it to dBs.
Right.
And half a dB per year is probably slowed. 2 dB per year is probably very fast. That's my
is that the
my very rough rule of thumb. But we probably need a committee to get together to define this, and probably it would depend on a person's age and the stage of the disease. In terms of how you interpret it relative to the intensity of therapy that you need to apply. And I would defer to some sort of consensus by glaucoma specialists, which is, I think, is needed.
Okay, well said. But 1 micron per year, are we actually able to detect? Is it possible? Is it that sensitive?
In terms of the overall average ganglion cell complex or nerve fiber layer thickness, yes, you can detect that. Over a couple of years, if you have 5 measurements, you can measure that trend, the speed of change.
Okay. So
what's the resolution of the machine now? With such a high speed, 200,000 scans per second, what's the resolution? 4 micron?
resolutions of the system optically is about 5 microns, but in terms of measuring the average thickness, because you can, from a map, for example, you can measure thickness over several hundred locations or thousands of locations. So when you average it, your precision improves a lot. So,
Okay.
Professor,
so you can measure, for thickness, you can measure down to a micron.
Okay. One more
If you
question for
average
you,
many
Professor
pixels.
David.
What's that?
One more question for you. This regarding the OCTA. Does it mean that, we have one machine and two technologies working with the two different principles to diagnose the glaucoma? That, the OCT NGO analyze the blood vessels, and the OCT, we look at the RNFL and the disc rim area and the GCC.
Well, OCT and geography is basically a series of OCT images taken consecutively and compare to detect motion. So OCT and geography scan includes structural OCT. So really, if you do an OCT and geography scan, it will provide both the perfusion and structural information. And I think in the future that would be commonly done.
For the OCTA, also the macular area is more important, or you would like to assess more the parapapillary area?
I think the macular area, if our experience with structural OCT holds, would be really important for monitoring progression. And also, I think it's important for the subset of glaucoma patients that have central visual field loss, which, as you know, is fairly common, and it would be better monitored by scanning the macula. It takes a lot of time to do a 10-2 visual field, and it's much easier to do a macular scan.
True.
So from the PG perspective, I just want to ask one more question to you, that how many percentage of the ganglion cells should be lost before we pick them up on the OCT?
How many percent of nerve fibers are lost?
Yes, the 40% ganglion cell when are lost, then we are able to pick up the defect on the perimetry. So,
well, picking up on perimetry, on an individual basis, it's quite variable.
No, that's
on the
right.
average,
but I have
about
read a couple of papers where they says that it is 15 to 20% of the ganglion cells are lost. Then only we are able to pick up the defect on the OCT, the RNFL.
From the tipping point paper,
yes,
the inflection point is about 40% loss.
14%.
40. 40.
40.
Yeah. But on an individual basis, sometime you actually pick up visual field loss before you pick up OCT. That's rare, but it does occur. And sometimes you pick up much later. So that it's a big spread.
Thank you.
Depending on because I think the main thing is there's a big individual variation in how well you can take the visual field test, and there's also a big individual variation in the nerve fiber thickness. So on an individual level, it can vary a lot, but on the average, 40% loss.
Okay. So now the people have started talking of that, if you perform the 24 days 2C, then you would be able to pick up the defect on the perimetry at pretty early stage. So is that right? 24 days 2C.
Oh yeah, that you will be able to pick up central defects better. Yes. Yeah. I think that's a great innovation. Yeah.
Yeah, I'm actually doing that on a routine basis now for especially the the new patients or the ones who are presenting now. Obviously, for purposes of comparison, you have to stick to whatever has been done in the past. Anyway, we really appreciate Professor Wang. We loved the interaction. We loved the way you gave us the time and taught us so many things, so many fascinating things. I'm sure we would all like to revisit your lecture to learn and learn again. Thank you for your time and have a
Thank you for the great questions.
Thank you. Thank you very much.
Have a good day.
Bye-bye.
Bye, good day.
There was a question that came in which is unrelated to this talk. So I will answer it. I did not pose it to Professor Wang, and that is the angle closure that happens or occurs following topiramate administration, is it reversible? Yes, it very much is reversible. It has to be recognized that it is due to topiramate. It will be bilateral, it will not be unilateral, and it will be recent onset myopia coinciding with the administration of topiramate. So you stop the drug and you just control the pressure. You do not need to do anything else. Please do not constrict the pupil. You could actually dilate because you want the iris lens diaphragm to go back, to pull back. So very much reversible. I hope that answers your question. And a very good night. We have a treat waiting for us. On Friday again, we have Dr. Tariq Sharawi joining us, talking about complications in glaucoma surgery. Thank you. Good night.
Thank you, ma'am.